Hi, so today our topic is going to be transplant rejection. So, just a little bit of overview that I want you to know. So, let's say this is the donor and this is the recipient. So the donor gives its organ, right? So, let's say this is a kidney. The donor gives their organ to the recipient, and this organ that is being transplanted, this is also known as graft. Now, normally it does not go very smooth, right? So there are going to be some mismatches. There's going to be some kind of immune mediated reaction by the recipient, and that leads to what is known as rejection, right? Or transplant rejection. And we are going to study the different types of them, right? So it is when the immune system recognizes the transplanted tissue as non-self that leads to immune mediated injury. So whenever the recipient cannot recognize a tissue or the organ as its own, that leads to an immune mediated reaction, right? So there are two types that you have to know. The first one is host versus graft. So what happens is, this is more of the general or the common one that we see. So what happens is that an organ from the donor, right? Let's say this is the kidney. When it is transplanted into the recipient's immune system cannot recognize it, and that's why it starts attacking the donor's graft, right? So that is known as host versus graft. So the recipient attacks the donor's graft, and that leads to rejection, right? And the second one is graft versus host. Now this is the complete opposite. So let's say this is the recipient and this is the donor. The donor gives its kidney or any other organ. Now what happens is that the donor's organ or the graft starts attacking the recipient, right? And that is known as graft versus host disease. So what happens over here is that the donor's immune cells attack the recipient. Now for rejections, there are three types of rejections. The first one is hyperacute, the second one is going to be acute, and the third one is going to be chronic. So the main way that I saw that is easy to differentiate between the three of them is going to be regarding the timeline. So if it starts from 0 up until 1 day, this is going to be hyperacute, right? If it starts from 1 day up until 6 months, now this is going to be the timeline for acute. And finally, if it takes from 6 months to years, that's going to be chronic. And this timeline can really help you differentiate between the different types of rejections. Okay, now first let's start with hyperacute rejection. So like I said, the onset is within minutes to hours. Now, how does rejection happen? It is due to the preformed antibodies against the ABO or HLA antigens. So remember, preformed antibodies. Now what happens is that I've already talked about ABO blood group and HLA antigens, which are going to constitute of your MHC molecules. So what happens is that your body cannot recognize its own antigens. So there are already antibodies that are traveling around in your circulation, and they will start attacking the graft. Why? Because it cannot recognize the ABO blood group, or it cannot recognize the specific type of HLA antigens because they don't match. Now, this is known as a type 2 hypersensitivity reaction. Okay, so hyperacute is a type 2 hypersensitivity reaction. And why? Because there are antibodies that attack your antigens, right? So that's what type 2 hypersensitivity is. So anyways, the antibodies, they activate the complement system, right? And when the complement system gets activated, that leads to more damage, more injury, especially at the endothelial injury. That leads to thrombosis, right? So the vessels, they start getting blocked. There is thrombus formation all around, and that's why there can be vascular compromise. So blood will not travel to the organ, and that leads to ischemia or necrosis of the grafted tissue. And one of the most classical presentations that I have seen is that they will talk about a kidney transplant operation, right? So as soon as they transplanted the kidney, they attached the vessels, and within minutes the blood pressure starts going down. The patient is getting hypotensive, and along with that the kidney is starting to get damaged, right? So it starts to become pale, cyanotic, and ischemic. right? And this is irreversible. So you immediately remove the graft. This is you're going to be your first line treatment. As soon as you see that the damage is very severe, the graft itself is starting to become pale, cyanotic, ischemic, mottled, right? You remove it immediately because it is irreversible. Next, we have acute rejection. So I talked about it. It's going to be from like 1 day up until 6 months. So the onset is within weeks to months. Now, acute rejection is a type 4 hypersensitivity reaction. And I've talked about this before. Type 4 is divided into further two groups. The first one is cell mediated and the other is humoral. Now, in cell mediated, what happens is that the CD8 positive T cells, they start directly destroying the graft cells, right? So you do remember the process, right? Where MHC1 presents the antigen to CD8 positive T cells. So the CD8 positive T cells then start attacking the graft cells. And as far as CD4 positive T cells are concerned, they start releasing cytokines, right? They start releasing interleukin 1, TNF alpha, and basically all of that causes inflammation and essentially damage to that organ. Next, we have humoral immunity, right? So you get formation of new antibodies, right? Now, this is different from hyperacute. In hyperacute, you have pre-formed antibodies. So they are already formed, right? But in acute rejection, you get newly formed antibodies, right? So make sure you know that difference. And again, if you have antibody formation, that leads to complement activation and essentially vascular injury. The important hallmark that I want you to know regarding acute rejection is going to be dense lymphocytic infiltrate in the biopsy. And I'm going to show you an image of that. So just know that whenever they mention lymphocytes or infiltration of lymphocytes, that's going to be regarding acute rejection. And another thing I want you to know is that whenever they mention a type 4 hypersensitivity, you have to know that lymphocytes are going to be associated with them, right? So that's the reason why in acute rejection, you have dense lymphocytic infiltrate. And acute rejection, it is potentially reversible if it is detected early and you start giving them immunosuppressants. So whenever we have a patient who has had a transplant, we are always putting them on immunosuppressants, and they can be like steroids, cyclosporin, tacrolimus, sirolimus, right? These are all of the drugs that we give them in order to decrease their immune response against the graft. Because if we don't give them immunosuppressants, their immune system can attack the graft itself, right? So that's why we always want to give them on immunosuppressants. And another point that is high yield, by the way, whenever we have a transplant patient, we automatically assume that that patient is immunosuppressed. And again, the reason being same, because they are on immunosuppressants. And when they are immunocompromised, right, this is a state of being immunocompromised. And that's one of the reasons why they are very prone to infections, right, which you don't normally see, such as CMV, right, cytomegalovirus. It is the most common cause of pneumonia in post-transplant patients, right? So you have to know whenever they are mentioning that a patient has had a transplant history, or if they are on steroids or immunosuppressants, you have to know that their immune system is compromised for the time being. So this is what acute rejection in a lung looks like. So you can see that it does not look like a lung tissue at all, right? Lung is supposed to be like filled with alveoli and with air spaces between them, right? But you cannot see that over here. So why? Because there are a lot of lymphocytes over here. So you can see this is a huge collection of lymphocytes. These are lymphocytes again. So coming back to my idea that there's going to be dense lymphocytic infiltrate in acute rejection. Okay, next we have chronic rejection. So in chronic rejection, like I talked about, it's going to be from 6 months onwards up to many years, right? I want you to know one thing in chronic rejection, right? And that one thing is going to be fibrosis. This is going to get you around a lot of the answers correct, right? So fibrosis, what happens is that the onset is going to be from months to years. It's again going to be a type 4 hypersensitivity, but this is what you have to know. the CD4 positive T cells, they start releasing cytokines, which are going to be PDGF, which is also known as platelet derived growth factor, and TGF beta. So PDGF is mostly responsible for your smooth muscle proliferation, right? So your smooth muscle proliferation, and TGF beta is mostly responsible for your fibroblast activation. So obviously, if your fibroblasts get activated, they start fibrosis. And that's one of the reasons why in these patients in chronic rejection, we have fibrosis, dense fibrosis. And when you have a lot of fibrosis around the vessels start becoming stiff. And that is one of the reasons why you get arteriosclerosis, right? So your vessels start becoming stiff with so much fibrosis. And the other mechanism is the type 2 hypersensitivity. And this is the reason why you have antibodies formation that leads to chronic vascular injury, right? And that chronic vascular injury can again contribute towards your arteriosclerosis. So key points that I want you to know is that first of all is a timeline. So it's going to be 6 months and onwards. And the key points are going to be fibrosis. This is the most highest yield point. And a lot of the times in Q banks, in NBMEs, the way that I have seen they ask regarding transplant rejections is that they always ask, what is the histological finding that you will see? So remember in hyperacute, right, you are going to see like antibody formation and preformed antibodies basically, right? And in acute rejection, you are going to see dense lymphocytic infiltrates, so lymphocytes mainly. In chronic rejection, the main point is fibrosis, right? So you have to know some of these histological findings, and that will get you most of the questions correct, right? So fibrosis, arteriosclerosis, atrophy, right? So obviously when a organ or when a graft is being damaged for a long period of time, for a chronic time, so that graft undergoes atrophy and loss of normal architecture. So whenever you take a biopsy of the organ or of the graft, you will see that it does not have the normal architecture that it's usually supposed to have. All right, finally, this is graft versus host disease. So the main concept is the same. The donor's T cell attack the recipient this time. So the things that we have discussed in hyperacute, acute, and chronic is that the recipient attacks the graft. But over here, the donor cells, the graft, it starts attacking the recipient. So it's the opposite, right? And this is mostly seen in bone marrow or stem cell transplantation. The reason being because these are mostly rich in immune cells and lymphocytes, right? And the recipient is usually immunocompromised. So someone who has HIV, someone who is on long-term steroids or immunosuppressants, right? So that is what this patient is usually going to be. And also a patient with cancer, right? So cancer is also an immunocompromised state. Now, this is what's important. The other organs of the host are damaged, not the graft itself. And let me just explain what it means. This is one of the most highest yield point that I can convey regarding graft versus host disease. And I have seen questions come up in this manner. So just listen to this. Let's say this is the donor and this is the recipient. Now the donor is giving the bone marrow, right? The donor is giving the recipient the bone marrow. Now in graft versus host disease, it is this bone marrow from the donor that starts attacking other organs, especially your GI tract, right? It's also going to be your liver, right? So the immune cells from the bone marrow, from the donor, it will start attacking other organs such as your stomach, right? So your stomach or your liver, it will start attacking that, but not the graft itself, because the graft itself is the bone marrow. So again, what happens is that other organs are damaged when you have a graft versus host disease. But in a transplant rejection, the graft itself is damaged. So what happens in the transplant rejection? This is the donor, this is the recipient. Let's say the donor gives their kidney to the recipient. In the recipient, the kidney itself is attacked. The other organs are not affected by it, right? So just know this difference. Okay, so this is going to be a type 4 hypersensitivity reaction. Why? It's because the donor's T cells are going to recognize the recipient cells as foreign, and that will lead to the immune response. So remember, whenever T cells or lymphocytes are involved, it's going to be a type 4 hypersensitivity reaction. And again, whenever you do a tissue biopsy, because it's a type 4 hypersensitivity, you will see lymphocytic infiltrates, and they mainly present with liver and GI issues. So liver issues are going to be like jaundice, right, hyperbilirubinemia, and elevated ASTs, AST, ALT, right. GI issues are going to be like diarrhea and severe abdominal pain, right. So these kind of symptoms mostly, by the way. And it occurs mainly with non-irradiated blood products. So like I said before, it is mostly seen in bone marrow or stem cell transplantation. So whenever we want to whenever we want to transplant a bone marrow from a donor to a recipient, we always want to irradiate it, right? The reason being because we want to eradicate the immune cells that are inside the bone marrow so that they don't attack the recipient. But sometimes it can be beneficial in leukemia patients. So what is leukemia, right? Leukemia is also known as like blood cancer, right? Just in casual words. So the problem that these patients have is that their bone marrow starts producing these cancerous cells, right? So let's say this is the recipient and this is the donor, right? So the recipient's bone marrow starts producing these cancerous cells, right, which are very dangerous. Now what happens is that if from the donor you give them a new bone marrow, right, now what happens is that bone marrow that was producing all of the cancerous cell is removed, but those cancerous cells that were in the blood, they are still present. Now what happens is that the donor's bone marrow immune cells, right? So the donor's bone marrow starts attacking the residual malignant cells, right? So I'm just going to explain this again. The recipient has cancer, the donor gives their bone marrow, the donor's bone marrow contains immune cells. Those immune cells will start attacking the recipient's cancerous cells, right? Again, this is the same concept. This is still graft versus host disease, but you are using that to your benefit, right? So it can be beneficial in leukemia patients.